Okay, good afternoon, everyone, and welcome. I'd like to thank Iridex very much for the invitation. I hope you all are having a great academy. My name is Yannis Paulus. I'm at the University of Michigan Kellogg Eye Center. It's an honor and pleasure to be here today. I've had the pleasure of working on ophthalmic lasers now for over 15 years, starting actually when I was a medical student back with Daniel Palanker at Stanford in 2005 and continuing to the present. So I think ophthalmic lasers play a very important role in our treatment of patients for numerous diseases, and it's been a pleasure to witness that and the changes in that since 2005 to the present day. So we'll be talking about retinal laser therapy today and going through my experience with that on patients, specifically focused on diabetic macular edema, and then we can talk about other things, and I'm happy to answer any questions that anyone has. Sorry, I had to turn it this way. For disclosures, I serve as an inventor on a number of University of Michigan patents, some related to retinal laser technologies. I serve as a consultant for Iridex, and those are the main ones relevant to what we'll be discussing today. And I've also co-founded some eye imaging companies, too. I'd like to start with a case since we're clinicians and that's what we're focused on. So a patient with diabetic macular edema. This is a 61-year-old Caucasian female who presented, had proliferative diabetic retinopathy in both eyes, had diabetic macular edema in both eyes, and had constant blurry vision, specifically in the right eye. She was receiving monthly bevacizumab injections in her eyes, in the right eye. This was actually the summer of 2020. The patient was very concerned because COVID, as everyone is very aware of, had popped up, and diabetic patients, and this patient in particular, was at much higher risk with that. So she had a lot of concerns about coming into my office, which she viewed as actually a very high-risk situation for her, and coming to see me. And throughout the pandemic, actually, I was seeing patients, since for retinal diseases, it is an urgent thing that we're seeing patients for, but she had a lot of concerns with coming in. The copay that she would have to pay with either aflibercept or ranibizumab was just too much for this patient, so she was looking for other options. Her past ocular history was remarkable for glaucoma suspect. She had cataract surgery in both eyes and a PVD. In terms of her, her main ocular meds was these intravitreal injections of the bevacizumab. Her past medical history was type 2 diabetes for 20 years, really suboptimally controlled. I practiced with a group of patients that unfortunately have a lot of difficulty on treatment of diabetes, had kidney disease resulting from the diabetes, along with numerous other metabolic diseases. The medications that she's on, as one would expect from having diabetes and hypertension and a number of other medical conditions. So for this patient in particular, her vision initially was 20/70 pinhole to 20/40 on that right eye, her symptomatic eye. The left eye was 20/25. Her intraocular pressures on that day were 12 and 14, unremarkable. And her examination otherwise was unremarkable. This was her OCT of the right eye. So here you can actually see that she has central edema, central macular thickness of 347, and she's pseudophakic. This was really the primary cause of why her vision on that right eye was so blurry, was this diabetic and foveal involving central macular edema. So she had been getting these monthly bevacizumab injections, and despite that, actually, that is that OCT reading. So I had a extensive discussion with the patient. We discussed different options with the patient. She was very concerned about the risk of COVID at that time. That was also when we knew nothing about COVID, except it seemed like everyone was dying from COVID. And she did not want to come into clinic monthly. In fact, she was refusing to come into clinic monthly. She was very concerned about steroids. She had a family member that had gone blind from glaucoma. She was a glaucoma suspect, and she really didn't want to receive steroid injections, which obviously is another option. And she elected to proceed with Endpoint Management Macular Laser Therapy on the right eye. These are the settings that I used: 30% of threshold laser, which in her case was 130 milliwatts. I treated her with 653 spots. Typically, I give somewhere around 500 or so. In her case, I gave a little more than that. Laser spot size of 200 microns, pulse duration of 15 milliseconds, and then the spacing there. 6 months after this laser, so she, like I mentioned, did not want to be coming into clinic every month. This is not someone that was coming Q4 weeks. This is someone that was very concerned about every trip to the clinic. 6 months after laser treatment, that red eye had improved from 20/70 to 20/30. The left eye remained very good at 20/25. She went from needing 6 intravitreal injections in the 6 months before to only 2 intravitreal injections in the 6 months after, and her vision was much improved. And her central macular thickness actually improved from 347 to 279. So still had diabetic macular edema, but a significant improvement, but most importantly, a significant improvement in her visual acuity, for which she was very thankful. So a comparison of kind of before and after. So the pre-laser visual acuity of 20/30, central macular thickness of 347, and then after endpoint management with actually a third the number of injections. She had gotten 6 injections in the 6 months before on the left there, and then actually just 2 injections in the 6 months after on the right here. A significant improvement in her vision to 20/30, a significant reduction in central macular thickness with a significant reduction in her treatment burden, and most importantly to this patient in particular, her number of clinic visits. So as I mentioned, she was very concerned about risk from COVID and so forth, and she was very pleased that actually I said come back in 3 months rather than come back in 4 weeks, which was actually her main concern. But very pleased that she was seeing better too. So this is another patient, diabetic macular edema follow-up, 57-year-old Caucasian man with moderate NPDR, diabetic macular edema of the right eye. And this patient was interesting. So he actually was a photographer. And for him, even though his vision actually measured fantastic, and oftentimes many patients with this visual acuity might not have any complaints, he was very symptomatic. And even the slightest change in his vision, he would come into the office and say, I'm blind, I can't see, I can't do my entire livelihood. I'm a photographer, I need to be able to see stuff, and I'm just not picking up the shots that I want to because I can't see well enough. So he was someone that was symptomatic, and his vision measured always pretty good on the visual acuity scale that we use, but he was very symptomatic, even with that good vision. He was receiving regular bevacizumab injections in the right eye. Of note, he was phakic. He had cataracts in both eyes along with dry eyes, and he had mature onset diabetes of the young Modi for 48 years. In terms of him, he did want to proceed with endpoint management macular laser therapy. He was very pleased with the improvement in the vision, but most important for him, he really didn't like also receiving the intravitreal injections. So he'd gotten 3 injections pre-endpoint management and 0 after receiving endpoint management. His visual acuity went from 20/30, he was kind of in the 20/25, 20/30 range, and improved to 20/20 after treatment. We used, these are the settings that you see here, the 30% of threshold with landmarks off, 200 microns, 15 millisecond pulse duration. Again, I typically target slightly over 500 spots, in this case 593, with 150 milliwatts as the threshold in this case. So this patient very pleased with the improvement in his vision, and also very pleased with the ability to get off the requirement for intravitreal anti-VEGF injections. So as we all know, diabetes, unfortunately, is a worldwide pandemic. That's a huge problem. Affects more than 387 million people worldwide. It's really increasing with the increasing prevalence of diabetes to 590 million in the next 10, 12 years. Diabetic retinopathy is the leading cause of preventable vision loss and blindness among working age adults, even in the United States. And increasing a lot in other countries too. Affects nearly half of patients with diabetes, costs over $13 billion a year in the United States. And results in 10 to 20,000 new cases of blindness annually. And photocoagulation has really been established as an effective treatment now for well over 40 years, and really is and plays an important role in treatment of patients. So there's a number of important reviews and so forth on the role of lasers. And so I know a lot of days now people say, oh, with the age of anti-VEGF, what are the role of lasers? And actually there have been op-eds on that. I've been very fortunate. The American Academy of Ophthalmology actually has a Munerlin Laser Surgery Education Center. And so I actually wrote with Mark Blumenkrantz a chapter on that, specifically on diabetes and using laser for diabetes. So actually on the second line there on the left, you actually see the website for the Munerlin Laser Education Center that the AAO puts out. And it's a fantastic resource that goes through a lot of the literature on it and the important role that it played both in the past along with in the current management of patients with diabetes. So I would highly encourage people to take a look at that. And then I give some of the different manuscripts that we have written and other people have written on the topic of retinal laser therapy and the importance of retinal laser therapy, both historically and in the present. And I do think that lasers play a critical role in our management of diabetes and numerous other retinal conditions. So pattern scanning laser, or PASCAL, where you deliver a pattern of spots with each trigger. I was very fortunate to do some of the early work on this in 2005 when I was a medical student actually at Stanford. You're really limited by the eye fixation time, about half a second, and so that's why oftentimes you deliver for 20 millisecond pulse duration, 25 spots or so. And you see here a video of the application of that with a single foot pedal application. You can give a whole grid. And so the conventional 100 to 200 millisecond pulse duration that we were using previously was really too long. And so this is actually one of our early studies in Archives of Ophthalmology, was looking at shorter pulse durations and looking at the effects of shorter pulse durations and showing that they're equally clinically effective negative, but actually they have the advantage of causing less damage to the surrounding neurosensory retina. And we found that 10 to 20 milliseconds was really the ideal compromise between speed and safety, and so that's why most commonly now with PASCAL treatments, those are the pulse durations that people are using. And so a comparison of the two, so on the left here you actually see PASCAL, where you give this uniform grid of treatment, and on the right you see a patient that actually had some PASCAL and some conventional laser, where you see on the conventional laser it's individual spots. Sometimes they're kind of very close, sometimes they're further away, and you can see a much more uniform grid-like pattern with the PASCAL treatment, and a big advantage of that. Looking at the evaluation of the retina after laser treatment, one of the important things that we actually ended up finding was that less intense laser burns actually cause less damage to the surrounding neurosensory retina. And so actually using these shorter pulse durations not only are equally clinically effective for the outcome, but actually have an additional advantage, which is they result in less of the unwanted side effects of this permanent scarring in the retina that you see with laser application. So actually not only is it equally clinically effective, but it's actually better. So that's actually one of the big reasons why we like to use this shorter pulse duration. And that really laid the groundwork for the work leading to endpoint management and evaluation of heat shock protein afterwards. We see these changes happening at a cellular level without actually killing the cells, without causing this permanent damage and blindness that can result from it, microscotoma. So it's really a big advantage and really what laid the groundwork for this endpoint management that we're using now. In terms of looking at it, what you can actually see here is the retinal ganglion cell receptive fields, and you actually see this filling in process at 2 months after the shorter pulse duration burns. So you actually are getting a complete filling in of the neurosensory retina and the ability to see within that region. So one of the things that we've been working on recently is using endpoint management to reduce the injection burden for patients. So one of the most difficult things for patients is that frequent intravitreal injections coming into the office every 4 weeks for these injections is a huge burden on these patients and their families. Much as we all like to say that we have very efficient practices, patients are not in and out within 5 minutes. It usually takes some amount of time for them to come in, get the imaging, get a clinical evaluation, and then get the injections and so forth. So this is a huge burden on patients and their families. And particularly due to COVID and the fact that many of these patients that are getting the injections are high risk, many of them are elderly patients, many of them have concurrent other disease states, they have a lot of concerns about coming into the clinic and sitting there for an hour in this waiting room and getting exposed. And so what we were looking at is the use of this endpoint management as an adjunctive treatment. So rather than using it necessarily as a sole treatment, which it certainly can also be used for, using it in addition to anti-VEGF injections to reduce the intravitreal anti-VEGF injection burden and also reduce the number of clinic visits that patients have to have. So we did a study where we actually looked at 18 eyes from 14 patients, and we actually looked at the number of injections that patients required before treatment and after the endpoint management. The patients had a mean age of 62 years, pretty standard for a lot of the diseases we're treating. 50% of patients were receiving these bevacizumab injections prior to laser treatment. 29% were receiving aflibercept, and the remaining received a combination of anti-VEGF and steroid injections also. And what we ended up finding was that you had a significant reduction in terms of the requirement for intravitreal injections after the administration of endpoint management laser. It almost halved it. So in the 6 months before endpoint management, patients were receiving 4.55 on average injections. In the 6 months after endpoint management, these patients actually had 2.33 injections, which was statistically significant. So there was a major reduction in terms of the requirement for intravitreal injections on these patients. Very importantly, you might say, well, maybe you're just injecting them less and the patients are losing vision and they're getting worse swelling, and so you actually have a bad thing happening. You're just not treating them. Well, what we actually found is the exact opposite, which is if you look at it, the patients are both seeing better and they have a reduction in their retinal thickness. So they're actually getting better treatment out of this. So if you actually look at the central subfield thickness before the endpoint management, it was 311. Afterwards, it was 301. So it wasn't statistically significant, but it was a clinical reduction of about 10 microns in terms of the subfield thickness. So, but the important thing that showed to me was it's not that they're actually getting more swelling and worsening vision. It's actually that even with having the number of injections, you actually are keeping these patients improving. In terms of the visual acuity, again, the same trend as the central subfield thickness, a slight improvement in the visual acuity, although not statistically significant. But the important thing that both of those show to me is that you're not compromising patient care. So even though you only have to give them half the number of injections, you're not actually causing the patients to get worse swelling or worse vision out of it. And so for me, the important thing, even though those last two are not statistically significant, to me, I just wanted to make sure that we weren't actually having adverse outcomes with these patients where they were seeing worse. And in fact, it's the opposite. They're actually seeing better and they have less swelling. So that was actually very reassuring to me that we saw that in this group of patients. And very important to the patients that they were able to reduce the number of injections. These are the settings that I like to use for endpoint management. 30% of threshold laser. On average, I usually get a mean threshold power around 140 milliwatts or so. I typically start around 100. Obviously, it depends on the patient pigmentation and a number of other factors. Most patients, I'd say, are in that 130 to 150 range. I always like to start below that to make sure that we're at a safe level. I turn off the landmarks. Some people, as they start, like to start with the landmarks on. I prefer to have them off so that I know the entire treatment area actually is really this endpoint management. Laser spot size of 200 microns, pulse duration of 15 milliseconds, the spacing. And in the study, the mean number of spots that I gave was 655 laser spots. So typically, most people are targeting over 500 or so, but usually I'm getting in the mid-600s. I typically do a circular pattern, excluding the two nasal quadrants, including the macular papilla bundle, and then I give supplemental 4x4 squares kind of in the temporal area and any places that might have, for example, a lot of exudates or microaneurysms. To me, the big benefits and versatility of the endpoint management is that it's a rapid treatment. So the patients aren't feeling anything with this outside of the macular contact lens. They report as incredibly comfortable, are very happy with the treatment, and they're used to other treatments such as intravitreal injections, which are far less comfortable for these patients. So they're actually very pleased with the treatment. I've had no patients with pain with the treatment. They really don't feel anything except for the contact lens, and I just give topical proparacaine or tetracaine for that. There's no requirement for fluorescein angiography, which is a big benefit over, for example, conventional focal laser treatments. It reduces the injection requirements, so you can really space out the intervals in between clinic visits for these patients. So many of them go from coming to see me every 4 weeks to coming in 2 months or 3 months, and they're very actually pleased. Even though they like seeing me, they don't like coming into the office so much and waiting so long. And really a trend that it improves vision and reduces the central OCT thickness. Not statistically significant, but most importantly to me, it's certainly not making it any worse, and a trend that it actually makes it a little better. And one difficulty on determining this is we have a pretty small sample size. So we were really looking at the number of clinic visits for these patients, and so we could do a larger study and might see a difference in that. But in this small study that we did, we didn't see a difference in that at all. Some of the key pearls when I'm doing endpoint management is it's important to set appropriate patient expectations. So in all patients, I mean with all surgeries and with all interventions, it's very important to have a discussion with the patients. In patients with severe diabetic macular edema, I find that laser reduces the number of injections, but doesn't entirely eliminate the need for injections. So you always want to kind of tailor it to the patient. You don't want to say, well, you're going to see 20/20 and you're never going to need injections again. I have not found that to be the case. Certainly on patients with mild edema, actually like the photographer that we were mentioning, that was the case. He saw 20/20 and he didn't need any injections. And so for mild to moderate edema, sometimes that's the case. But for severe edema, in my experience, it's more that they will need some injections, although fewer injections. You could consider endpoint management as monotherapy for milder, such as mild to moderate edema. But I typically oftentimes actually use it in patients for severe edema to reduce the number of clinic visits that we have to do. And you always want to counsel these patients. These patients are oftentimes used to anti-VEGF injections. And with anti-VEGF injections, you get this pop where there's a pretty significant improvement in their vision 3 days later. And so many of them are used to that. And so I want to make sure that they don't expect that here, because with the laser therapy, actually, you don't get that initial pop after a couple of days. You actually get this kind of long-term effect. So I always want to counsel them on that, because if not, after 3 days, they're going to say, oh, you didn't give me good treatment, because I usually get this significant improvement with intravitreal injections, and I didn't get that here. So making sure that they are aware of that and expecting that will really help out in terms of having sure patients are on the same page as you are. I typically select patients that need frequent, oftentimes monthly injections, and particularly those that have a lot of concerns about coming into the office so frequently. Those are the ones that really can enjoy me saying, see you in 2 or 3 months rather than see you in 4 weeks, and trying to extend it out in between. And then walk patients through the entire procedure, what to expect during the process in terms of the drops, in terms of the contact lens, and then keep track during the treatment of the treated area, since I use no visible landmark, so there's really no indication of the area that you've treated. And so you just want to keep track of where you are and what you've treated and what you still have left to treat. So those are the main pearls, but overall I'd say it's very easy to pick up, and I'm happy to chat with anyone about it and so forth, but very easy to pick up. I do also want to thank all the members of my lab for the people. I had a number of med students that assisted with this trial and so forth, and it was very helpful to have their assistance on all the things. I also want to thank all of our sources of funding, primarily the National Eye Institute, and I want to thank you all very much for your attention. And I welcome any questions that anyone has. Please.
You said you usually use around 500 spots. What made you decide on that number?
That's a great question. So it really hasn't been comprehensively studied. So what I try to do is I try to paint and treat the entire macular region, and that's just the number of spots that I end up needing to usually cover that region. So I'm using the spacing, the 0.25 in terms of between spots, and that's kind of when I paint from arcade to arcade and avoid the papular macular bundle along with the central foveal area, the number of spots that it takes. But we have not done, and I don't believe anyone's done a comprehensive study looking at 400, 500, 600, 700, exactly how many spots are necessary to achieve the therapeutic endpoint. It's just kind of a way to paint from arcade to arcade, avoiding a certain area.
Hey, doctor, have you used the endpoint management on a asymptomatic patient? So a patient comes in and they say, hey, I'm seeing fine, but on your OCT you see some stuff percolating under the RPE or under the retina that they're not effective yet. Have you lasered while they're there and say you see something going on before the patient notices any symptomatic
Yeah,
stuff?
that's a great question. And it's a little bit of a debate, I feel like, in the retina community about how to treat patients that are asymptomatic with good visual acuity. And certainly the DRCRnet has done some studies looking at anti-VEGF injections in that population. My general philosophy is that our goal is to get patients to see better, and our goal is to help patients with the visual complaints that they have. I'm always very hesitant. My general thing is when I'm discussing with patients, if something's not broke, don't fix it. I'm very hesitant to jump into a patient and do an intervention, either laser or injections, which obviously carry risk of infection and so forth, if they're asymptomatic and if the vision is excellent. So I base it a lot on their visual acuity. I base it a lot on their OCT thickness. I do have concerns that if there is a significant amount of swelling over the long term, it can cause retinal atrophy and vision loss. And I think we have good data indicating that. So I will base it a lot. I can't give a standard answer for you because I actually base it on the individual patient, but I would base it on the location of the cysts on OCT. I would base it on the central macular thickness on OCT, and I would base it on the visual acuity. And also, obviously, on the patient complaints, but you're saying the patient doesn't have any. So if there's significant edema that involves the central fovea and isn't going away, so I'd also probably wait for a period of time and not necessarily laser them the first time I see them. If there is significant, I would be concerned about long-term atrophy and vision loss from that. And once you get that vision loss and atrophy, there's nothing you can do to reverse it at that time. So I would start, I'd say, in the clinic encounters with education of the patient, of showing them their pictures. I very much like to get patients engaged by showing them their imaging and say, look, you have swelling here from diabetes in the center part of your eye. If that stays there, we're going to have more discussions about how that's impacting you, both in the short term and the long term. But I would be very hesitant to jump into a 20/20 eye with juxtafoveal edema that is asymptomatic. I'd hate to jump into doing an intervention because in that case you have no place to go except down.
Wait before you. So in that case, how long would you wait for the patient to say come back in a month, come back in 3 weeks, or what's your time frame to come in and do a side-by-side comparison to say, hey, this hasn't gone away, we need to do something, or?
I'd typically see them about a month or so later. So I'd base it on, I'd see them a month later and we'd see the trajectory it's going. I also like to use that as an opportunity to educate the patients. Many of the patients, the first time they come in to see me, have very poorly controlled diabetes. They might have A1Cs of 13, 14, 15. And use that as a learning opportunities for these patients to actually try to bring that down. And if I see that A1C come down, if I see their diabetic macular edema getting better on its own, I might not do anything. If I see that their A1C remains elevated or actually gets worse, their swelling's getting worse, their vision starts to become affected, 20/25 and so forth, that might actually be a good opportunity to intervene at that stage too. And typically once you start to have an increase in terms of the diabetic macular edema, many patients will start to get symptomatic. So I mean, we're fortunate to have two eyes that work, so sometimes they're not necessarily symptomatic in their everyday life, but actually if you cover up that one eye and you ask them to read something, then they struggle a lot more. And that's how you can really impress upon them that even though you see well enough to read, if I were to take this other eye out of the picture, maybe you don't see as well as you think. And so really educating them on each eye and making sure that we're optimizing each eye in case something were to happen.
After an endpoint management treatment, when do you start to see results, and when would you say those results have peaked?
I don't know that we have great data on that. My general experience has been that we start to see results in that 2 to 4 week range. So unlike anti-VEGF injections where you get this pop 3 days afterwards, it's more of a gradual process. I'd say usually I counsel patients that on the order of like 1 to 4 weeks, they'll start to see effects. And you can oftentimes see effects for 3 to 6 months, and that's actually, to me, one of the big advantages of it. You certainly can repeat it. I have done less repeating than I know some of the other retina specialists that use it. I think Dr. Gonzalez will also be speaking later on, and I've discussed with him, I think oftentimes he'll repeat it 3 months later. I actually more do on the order of 4 to 6 months later if I do repeat it, because I feel like I'm seeing a lot of patients that have a treatment effect many months down the line. So I would say it's a pretty durable in terms of its duration of action. Onset of within 1 to 4 weeks, not the 3-day pop with anti-VEGF injections, but a little bit longer. And then the duration, to me, is the big advantage, where rather than anti-VEGF, where it might wear off after 1 to 2 months, you actually see more, about 3 to 4 times that, where it's more like in the 3 to 6 month range that you see a duration. So I oftentimes will wait a significant period of time in between doing repeat treatments, most commonly about 6 months in my experience, but I know some people that do it as frequently as every 3 months or so.
Dr. Paulus, what about CSR? Have you treated patients with CSR with EPM, and if you saw somebody today and you diagnosed CSR, would you laser them today or have them come back maybe in 2 to 3 weeks or within a month and do another evaluation on them?
Yeah, that's a great question. So for central serous choroidal retinopathy, I have treated patients with that. I didn't include that in this study here too. I think it depends on the stage to answer your questions about when I would treat that patient. So if they're in acute phase, central serous choroidal retinopathy, this is the first time that it occurred. In most cases, what I'll do is I'll start with observation, because many of those patients will actually resolve on their own. So typically I will look for any either stressors or corticosteroid use and reduce that, and then I will see them back some period of time, 6 to 8 weeks later, and see how it's responding. At the point that we're considering treatment, usually the 2 main treatments that I'll have a discussion with on that patient will either be photodynamic therapy or endpoint management. I'd like to see a head-to-head comparison of the two, actually. I think there's good evidence for each one individually, but I have not seen a good prospective randomized clinical trial actually looking at those 2 treatments. I think there's good studies, particularly with photodynamic therapy, in terms of that as a treatment for central serous choroidal retinopathy, but I'd like to actually see a head-to-head comparison. I typically offer both to patients. Given the side effects of photodynamic therapy in terms of the requirement to avoid sun, in terms of risk of choroidal hyperperfusion and so forth, I typically will actually start patients, I'll counsel them on both and give them the option. Most patients, and for all clinicians, I'm sure everyone knows that everything always depends on how you frame things. So I think physicians play an important role in the consent process, because how you frame things to patients probably affects their decisions a lot more than we like to think. With the way I phrase things in terms of side effects and so forth, I find that most patients choose to do endpoint management before proceeding with photodynamic therapy with central serous choroidal retinopathy. I usually will offer both to them. And when I discuss kind of the risks, the benefits, and the alternatives, as we do before any procedure, most patients I feel like the endpoint management is a better choice for them, primarily because the risks are significantly lower. In terms of the efficacy, I don't think there's great data comparing one head-to-head against the other. In my experience, they're actually both equally effective. There are many patients that actually respond to either one of those. And so when I do the consent process, most end up deciding to do endpoint management. I have a smaller group of patients just because I don't have as many patients with central serous as I do with diabetic macular edema, but at this point I probably have about 10 patients or so that I've treated with central serous, and the majority of them actually have a great response. As those who treat central serous choroidal retinopathy know, there are some patients that are very refractory, and unfortunately, even with endpoint management, even with photodynamic therapy, even with a number of treatments, still unfortunately will have edema and or poor visual outcomes. But the majority of patients actually, that does the trick. So I would say I've definitely have experience with central serous choroidal retinopathy, and I think it's another great indication for it.
Just a comment, and you said it earlier before with the diabetic retinopathy and somebody's A1Cs. I mean, patients have a little skin in the game too. I mean, they have to take care of themselves. They have to watch their diet and exercise, and smokers and whatnot. I mean, you can do all you can do as far as laser injections and whatnot, but patients have a little skin in the game too.
Absolutely.
I mean, you're talking about the education process and everything.
Yeah, I completely agree. And I feel like as clinicians, part of our goal is actually to get that, to get patients to buy in and to get patients to see what we're seeing and to understand what we're treating so that they actually completely have skin in the game. Because I think the more they're invested in their own healthcare, the more they're invested in understand what it is that we're treating, the more likely they are to work with you, the more likely they are to get that diabetes under good control. So I completely agree. And in our clinic, I actually have literally things that are about this big where I pull up their OCT images and I pull up their last one and I pull up today's and I say, this is how it looks. Because I think that education process is very important for patients, because that's how you get them to get skin in the game, and that's how you get them to understand, because everyone wants to be able to see, everyone wants to have good health, and it's identifying what's keeping them from doing that. And in many cases, just patients don't understand. Patients don't understand, this is why I can't see, is this cyst here from diabetic macular edema, because they're not seeing it like we are. So I think that patient education part to me is absolutely critical, and to me is very important in my clinical practice.
Dr. Paulus, are there any patients that you find you would see as a contraindication to using endpoint management?
I don't, because you're not creating permanent scars in the eyes. I don't actually have a large group of patients that I would avoid it on. Certainly patients that have had extensive focal laser therapy with kind of conventional spots and have a lot of macular atrophy are ones that I have more of a concern about, and those patients oftentimes will have a concern about more laser treatment, because many of them will be symptomatic with blind spots in the macula. So a relative contraindication in my mind is someone with a lot of macular atrophy, because in that case, that patient might not have as much kind of room to go and so forth, and particularly they might actually be very leery and hesitant of additional laser treatment, because the laser treatment might have been what currently makes them so symptomatic with a lot of scotomas in their central visual field. So I've treated some patients that are like that without any adverse events on those patients. I wouldn't say it's a complete contraindication, but I would say if someone has a lot of macular atrophy from prior laser treatment, that I'd hesitate a little bit on those patients. I haven't had from endpoint management any patients that have progressed like that. So I think that's an important point. So it's not a complete contraindication, certainly.